Okay, welcome everybody. Thank you for coming tonight. Beautiful night out there. And we're really privileged tonight to have, every once in a while, someone from every once in a while, I would like to think it's all the time, but it's not as much as I would like. Somebody from the University of Montana makes it big. And then every once in a while, they'll come back and share with us what they've accomplished as a result. Tonight's speaker falls into that category. Tenley Snow was here at the University of Montana several years ago. I knew her best when she was the Peace Corps representative on campus. And she served us well for, was it 2 years?
It was about a year, I think.
A year only?
Yeah.
It seemed like it was longer than that.
Yeah, it seemed a little longer.
And she was a student at the same time, a graduate student, and also she worked very closely with me and helped me set up the minor in global public health, which some of you are benefiting from today. So she's gone on to do good things with Village Reach, and we've heard from Jessica Crawford about Village Reach already. And Tenley, we're just really blessed that we have 2 talks about Village Reach this year. And Tenley's going to talk about some of the data visibility issues with regard to her role with Village Reach. And so I'll ask you to join me in welcoming her here, and then I'm going to ask her to elaborate if she needs to on her background, since I last saw her, which was, how many years ago now? 5?
It's been a while. I graduated in 2013.
All right, so it's 4, close to 5. All right, let's give Tenley a warm welcome. All the way from San Francisco.
Pasadena, California. Yep, right outside of LA. So thank you so much, Peter. I really appreciate it. I really loved my time when I was with University of Montana, and especially working as the Peace Corps campus recruiter. So I was working as the recruiter during graduate school. So I was actually at the University of Montana from 2010 to 2013 in the International Conservation and Development minor through the College of Forestry and Conservation. So I actually was here for graduate school, so I wasn't able to partake in the Global Public Health minor, unfortunately, but I did work really closely with Peter and was able to help inform the requirements for that and really kind of help inform the curriculum. So I came to graduate school after my undergraduate at Whitman College over in Walla Walla, Washington. And then I served in the Peace Corps from 2007 to 2009 in West Africa. So I was in Senegal, West Africa. And then I came back here and got the job convincing other people to give away 2 years of their life unpaid to the Peace Corps and making a difference globally. So I will shamelessly put in a couple plugs here and there for the Peace Corps. I don't know if anyone's thinking about it, but I did work as a recruiter for a while and had a lot of experience with Peace Corps. But today I would like to talk to you about my work that I'm currently doing with Village Reach. So you heard from Jess Crawford, who's my colleague with the Health Systems Group at Village Reach, which is a small nonprofit based in Seattle. But I work with the Information Systems Group. So I will tell you that, again, maybe you can talk with me afterward or take some inspiration from the fact that I was an English major as my undergrad, and now I'm an information systems manager. So it kind of doesn't matter what you major in. We were just having this conversation before some of you walked in. It kind of doesn't matter what you major in. Your path will kind of find its way depending on what you're interested in, and wonderful people like Peter who give you an opportunity to participate in different things and gain experience. And all I can say is really push yourself to kind of spread out your interests and push your boundaries, because the more you do that, the more opportunities you'll give yourself. So today I'd like to talk about what we like to call reaching the last mile. And I'm sure Jess talked a lot about what the last mile means, but when we talk about healthcare and providing healthcare to rural areas in underserved countries, we call that kind of the last mile. So getting down that crazy road to that little tiny health facility in the bush somewhere in the middle of nowhere, that's the last mile. So today I'll be talking about how having data visibility can really improve health outcomes in low and middle income countries, and so how data visibility can really increase the provision of health services and health products to those low and middle income areas. So when I say the word supply chain, does that mean anything to anyone? Does anyone, what do you think of when I say supply chain? Anyone just want to like kick an arm out there and shout it out? Any thoughts? Yeah.
Like the distribution of resources from the point where it's like made or whatever, all the way down through the line to whoever needs to receive those resources.
Absolutely. That's like a perfect, crystal clear explanation of what supply chain is. It gets a whole lot more complicated than that, but that's an exact explanation of what supply chain means. It's basically getting product from point A to point B and all the steps that are in between. So when we're talking about supply chains in the developing world, it gets really, really, really complex. So kind of starting at the top, we have a number of different what we call programs, essential medicines, ARVs, which are HIV treatment drugs, TB, malaria, family planning, vaccines, et cetera. So all of these different programs have different considerations, and then they get split into sub-programs, et cetera, et cetera. Then you have all the different funders, and that can be WHO, Global Fund, USAID, DFID, the UN, absolutely all different kinds of donors. So you have all of those donors and all of their considerations. Then you have the procuring agents or bodies. So those could be private procurers in a country. Those could be ministries of health. Those could be bilaterals or parastatals in the country. So all of those different procurers who are bringing in, specifically we'll be talking about health commodities, so bringing in health commodities and products to those countries. Then from kind of that central level, when you've procured the drugs, you have all the different levels of warehousing and distribution throughout the country. And every country is different. In Liberia, for example, they have the central level, and then they have what are called counties. But when you're talking about countries that were Francophone or were colonized by the French, you have regions, districts, and health facilities. So you have all kinds of different levels in different countries that the supply chain has to address. So it's an incredibly complex situation, and there's no one easy answer for how to address this. So there are some major supply chain challenges. I just named a couple of them, one of which is transportation. So getting product from point A to point B. These are some pictures that I took when I was working with John Snow Incorporated. It's a private organization based in Washington, D.C., but they were one of the largest contractors for USAID for the procurement and provision of health commodities. So these are all USAID-funded malaria bed nets, and so these are bales of 50 to 100 bed nets that were all wrapped up into what conveniently look like large bales of drugs, but they're not. They are mosquito nets. It's okay to laugh. It's all right. No, these were mosquito bed nets. So this was a delivery that we were distributing to Benin, in a country in West Africa, specifically to pregnant women. So trying to protect women who are at greater risk of contracting malaria. Pregnant women have increased body temperature, and mosquitoes are more attracted to pregnant women, so they're at greater risk. And then that can cause stillborn fetuses and birth defects and a large number of problems for unborn children. So we were trying to get mosquito nets specifically to pregnant women. And so this was, I think, a delivery of 740,000 mosquito nets. So that came out to something like 15,000 bales of these, and each one of these weighs about 100 pounds. So you were talking enormous amounts of product. So talking about the transportation of those, talking about the warehousing of those products. So ministries of health in small countries are typically the ones who manage warehouses. But very often they don't have the funds, they don't have the resources to adequately warehouse and protect product from things like, sun, mildew, rain. Things like vaccines need special care for things like the cold chain, so keeping vaccines cold. So warehousing is a really major challenge and consideration. Some other considerations are things like storage. So when you're at a smaller health facility, these were bottles, I believe, of some kind of reagent or liquid that they were using at a small health facility. Typically, there's absolutely nowhere to store all of this product that gets sent out. So storage is a major challenge. And then finally, infrastructure. I can't count the number of times I've driven on roads like this trying to get product delivered out to these little tiny health facilities at what we call the last mile. So just the enormous amount of challenges from getting product from that central level, that nice, you know, moderately shiny capital city that you land in, all the way out to the little teeny weeny health facility with no electricity, no internet in the middle of nowhere is a major challenge. So I just wanted to kind of stop and maybe ask a question here. How many times have you guys gone to the doctor maybe to get your last, I don't know, Hep B vaccine or something, and have the doctor say, I'm sorry, we don't have that today, and I don't know when we're going to have it? How many times has that happened to you? Anyone? Is that never? How many times have you gone in to get like a Z-Pak or an antibiotic for something and had them say, we don't have it, and we probably won't have it for the next 6 months. You might have to go to the hospital down the road that's 50 miles away. Never happens in places where we have adequate supply chains and we don't face these major challenges. Not to say that there aren't still challenges to American healthcare, but things that come down to this very, very sort of raw level of trying to get these products from point A to point B just don't really happen. So this was a photograph that was taken by Village Reach during some of the work that we were doing, and this is a pretty common sight at little tiny rural health facilities, people lining up to try and get care, maybe because they heard that this particular health facility had just gotten in a batch of stable vaccines. Or maybe they just heard that they just got their refrigerator fixed, and so they would have cold vaccines. Or maybe they just heard that they got new malaria bed nets. So, you know, the considerations for healthcare in these small rural areas are very, they're very volatile, and it can be very difficult to find the healthcare that you need. So how do we really ensure that we're getting the product to those who really need it? So one of the ways is through accurate data and good data visibility. So we like to say that the last mile of healthcare delivery is the first mile for data. So that's the first step that data starts to come back up the supply chain. So we get product from the central level all the way down to that little tiny health facility, but then how do we get that data about how much they got, how much they need, how much they used, you know, what products they're stocking out of? How do we get that information back up the supply chain to inform the planning? So we like to say that data management is a key component of any supply chain to ensure that product can reach those facilities and that it's adequately stocked, so that you're not having what are called stockouts. Stockouts are kind of the scary word in commodity management. It's like you don't want to have stockouts, but countries are often facing 40, 50% stockouts in their health facilities of several products at any given time. So stockouts are a major challenge that is faced in this kind of management. Using data to be able to assess need and performance over time. So being able to say, is this health facility getting enough product? Are they getting enough of the malaria treatment drugs that they need to treat children, women? Are they getting too much? Because an overstock is just as bad as an understock. If you get too much product, you're wasting that valuable product that could be going somewhere where it's needed. And then two, you're also running the risk of having expiration of valuable product. And then finally, using data to increase efficiency and improve processes. So being able to look at the supply chain and say, this is what a health facility needs, and being able to increase the efficiency with which we plan and then move product out to those health facilities. So there are really some major challenges to data capture. What I've run into in my work, and what I think is a very common thing that we're still facing, I would say in most of at least sub-Saharan Africa, where we do most of our work, and where a lot of the sort of lower income countries are located, paper-based forms. So if you're thinking about a health supply chain and countries are making an effort to track the commodities through some kind of data management, most of the time health data and logistics data are the two kind of primary pieces of data that ministries of health want to capture. So health data, what do you think I mean when I say health data or health management data versus logistics management data? Anyone want to hazard a guess what that might mean? Yeah.
Maybe like their medical history
Mm-hmm.
versus the
Yeah. Okay. Any other thoughts? Yeah.
like who's getting sick with what and where.
Yep. Absolutely. Yep, that's good. So health management information data is disease incidence. So how many malaria cases were treated at a health facility? How many pregnant women came in? Were they complaining of fever? How many, essentially disease incidents? How often was someone coming in and complaining or being treated for a specific disease? Logistics data, on the other hand, is how many particular doses of ASAQ, which is a malaria drug, how many doses of this drug were dispensed at this facility? So there's logistics data and there's health data. And those are really the two primary pieces of data that are captured and compared at small health facilities. But the problem is that at most health facilities, you have what's called a HMIS, which is a Health Management Information System, and an LMIS, which is Logistics Management Information System. Both of those, HMIS and LMIS, both are typically still captured on paper-based forms at the health facility level. There's a number of reasons for that. Often there's very low connectivity, so probably little to no internet connection at those health facilities. Often there's not even electricity at those health facilities. But then also, that's just kind of the process that's been in place that they were able to manage. And it takes time, resources, training, and a certain level of capacity to have an electronic system put in place. So right now, most places are using paper-based systems. This background picture is one of the kind of paper forms that we used as a proof of delivery to deliver those bed nets. But the paper-based forms can be really challenging for a number of reasons. They're extremely time-consuming to fill out. They're often out of date, so they can be many pages long. They can include every product that's ever been distributed in that country. They can be 10 pages long, little tiny writing. They are often not available at the health facility. So officers in charge at a facility are expected to fill out data for their health facility, and they wouldn't even have the forms. They're very inefficient, so you have to kind of hunt and peck to find the individual product that you're trying to fill out information for. Another major point that is a big challenge is that there's manual calculations that are done. So, for example, if you're talking about your logistics data, you would say, this was our beginning balance, this was what we consumed throughout the month, and this is our stock on hand. But you're making a manual calculation. How much did you consume? How much did you have on hand? And so those manual calculations can create error. And then finally, they just create waste. And if you visited some of these lower income countries, they typically don't have waste management systems. So we have ways to deal with garbage in developed countries. They do not have ways to deal with garbage in these countries. So you'll see large amounts of paper waste based on these kinds of forms. Like I mentioned, there's often very limited connectivity at the health facility level. So they often have to rely on paper-based forms. I'll talk a little bit about mobile data collection technology, which is used through like an SMS or a cell phone. But right now, most health facilities are filling out their data using these paper-based forms. And then finally, some data quality issues that come from using these kinds of forms or just kind of general data quality issues. Proliferation of data points. So there may be just too many things to report on. So most health facilities are not just having an expectation that they're reporting for the Ministry of Health and that's it. They may be receiving product from UNICEF, USAID, and the ministry, and they may have separate reporting expectations for each of those donor organizations. So there's a proliferation of data points, health information, logistics information, different donors. There are data collection tools that aren't used at the health facility level. So there may be some kind of data collection tool that's used at a regional level that is not used at a health facility level. So right there you have a gap in that information and understanding. There may be a lack of time for the completion of the data collection and aggregation. So if you're expected to report on a monthly basis, you don't even have your paper forms. You get your paper forms 3 days before you're supposed to turn them in. Then you have, I don't know, 1,500 data points to collect information on. You're not going to have enough time to get that done. So sometimes we'll see in countries there will be a 6-month lag of data flowing up from health facilities up to the central level, because it takes that long for data to be filled out, move up to the regional level, to the district level, up to the central level. So it takes a very long time, and there's a major lag in data. And then finally, a lack of connected systems. So kind of when I went back and showed that complex supply chain environment, the electronic systems in countries can tend to be very, very complex as well. They tend to be siloed, so meaning they only manage a certain product, they only manage HIV drugs, or they only manage family planning drugs. So they tend to be siloed, they tend to not be interoperable with one another, they tend to just be not connected. They're gathering information on different key indicators. So one indicator may not match the indicator in another system. So just generally, there's a lack of connectivity between the systems that are being put in place in countries. And also different donors have different systems that they want to push. So UNICEF may have their particular system that they've put together, or UNFPA may have their particular system. So definitely a major challenge when you're talking about different electronic systems in country. So like I was just mentioning, there are some major information system challenges. So now we've kind of gone from the challenges with paper-based forms to talking about the information systems that can be put in place in country. So like I was mentioning, they may be fragmented solutions, program-specific, level-specific. So you may have a system that only functions at the regional level, but does not provide visibility up and down the supply chain. Paper-based systems, a major one that I'd like to focus on is systems are proprietary. And do you know what I mean when I say proprietary? Anyone? What do you think I mean when I say proprietary? I know, you're like, I just wanted to sit here and listen. I don't want to answer questions. Anyone, any thoughts? Yeah.
It's owned by a particular provider?
Exactly. Yep, great point. Yep, so proprietary means that it's essentially, it is pay to play. So it's owned by someone and you need to pay to use it. So the reason I wanted to specifically talk about proprietary systems is because the work that I am doing is on open source systems. So I'm going to ask another question, and I want to hear like a big, woo, let's answer. What do I mean when I say open source? Anyone? Any computer nerds in here other than my husband? Anyone? Open source. Yes?
It's like open access to everybody. Nobody really has claims on ownership.
Yep. Yep, you're awesome. So yeah, open source software means that it is non-proprietary. So an example of open source software is Mozilla Firefox. Linux is another example of open source software. So what that means is that the code for the software is freely available on the internet. It tends to live in something called GitHub, which is a data code repository, but what that means is that the code is freely available for use. So Peter, you could go and download the code for OpenMRS right now if you wanted, and have your own electronic medical record system in your home. So anyone with the know-how can take that code, it's freely available, and it can be downloaded. So why is this an important consideration for countries? Because proprietary systems can get very expensive. And they are owned by a specific entity. So like Microsoft, for example. Do you get Microsoft Office for free on your laptop? Nope, got to pay for it, and it's kind of expensive, right? Same with the information systems that are available. Something like IBM. They have a really powerful, great data information system, but it's really expensive. So open source software is an excellent option for low and middle income countries that are developing, because they are able to take that code and, instead of spending the money that they have from donors or from the ministry, instead of spending that money on a proprietary license that they have to pay for every year, they can spend that money on training. They can spend that money on hardware and infrastructure. They can spend that money on actually putting it to good use on the software in the country, rather than paying someone for a proprietary license. So there is a proliferation of open source software available now. I just laid out a few of the major ones that are really big players in the health commodities and global health kind of landscape. So my project that I'm working on is Open LMIS. So like I was talking earlier about LMIS, HMIS, so Logistics Management Information Software. So I work on Open LMIS, but there are a number of other open source software that do everything from electronic medical records, smart registers for client-patient registries, billing, accounting, and inventory management. OpenHIE is the interoperability layer. It's a little bit more nebulous, but it's essentially an interoperability layer for being able to connect some of these different systems. And then the other big player is DHIS2. So I don't know, you've been studying global health, and maybe eventually you'll get into this kind of software, but DHIS2 is an HMIS software. So like I was talking earlier about disease incidents, it's health management software. DHIS2 is implemented, I think, in over 50 countries now, so it's very prolific. It's run by the University of Oslo in Norway, and it is everywhere, and it's used for a very large number of different types of health management, information management. So DHIS2 is kind of the big player and the big takeaway for HMIS data, and we're really pushing for Open LMIS to be like the standard for logistics management software, for open source software. And then finally, like I talked a little bit earlier, there are also mobile data collection apps. So when you go to that last mile, there is no computer, there is no internet. It is still possible to do electronic data capture, but you tend to need to use some kind of mobile solution. So something like ComCare Supply or Logistimo, those are just a couple examples. There are literally dozens of mobile technologies that can be used. Some are proprietary, some not. Using SMS, using tablets to collect data. So there are a lot of different options. All of these kind of function at different levels in the supply chain. But open source is really an excellent option for countries as they're looking to implement a system and manage their data. So how can improved data help health programs and help supply chains? So having better quality and more easily accessible data can help with supply chain performance. So reducing the time for data transfer between levels can mean that orders are placed sooner and product is delivered faster. So like I was saying, there can be like a 6-month lag in the data flow between supply chain levels. If you can get that data flowing faster, that means you can get orders placed faster. That means you can get that product out to health facilities. Might be the rainy season for 3 months, and you might not be able to pass on the road or the bridge to get to that health facility, but that's like an act of God. But at least we have the data available. Service delivery. So knowing that a facility needs a certain amount of product, that means that they can be resupplied more quickly and they can provide those much needed services. So they can get those vaccines to children. For example, in Liberia during the recent Ebola crisis, having improved data using a number of different tools, mobile data collection tools, they were able to get treatment, understanding the disease incidence for the Ebola outbreak, and now there's actually work on an Ebola vaccine as well. So being able to get that out into those small areas that were the hardest hit during crises like those is kind of why we do the work we do on data. Finally, forecasting and quantification. This one sounds kind of boring, but it's very, very important. So when a national program is looking at its overall needs for the country for the next maybe year or 2 to 3 years, it's extremely important that you have quality consumption data. So how many doses of ASAQ malaria drugs did we consume this last year? And once we know that, we can compare that against population data, and we can figure out or determine how much we'll need for the coming year, how much we'll need in 2 years. So in order for countries to place accurate orders and for donors to accurately provide the correct amount of product, having good data for forecasting is extremely important. Then finally, data for management. So having quality data can allow decision makers and program managers to review key data points, reveal trends, and then build context to make a case for known and new issues. So if you're seeing that you're having a stock out in a certain area and you don't know why, having that data available as a program manager allows you to say, these areas are stocking out, why are they stocking out? And using that as proof and context to build a case to address those issues. So being able to kind of focus on known issues in a country and then also to explore new issues and find responses. So quickly, just what is Open LMIS and how does it help with data availability? So Open LMIS is an open source, so it's web-enabled, so it's cloud-based, enterprise class logistics management information system, and it was purpose-built to manage health commodity supply chains. Open LMIS is an open source software and it's an open source community. So what I mean when I say that is that there are multiple donors, funders, developers who contribute to the software. So rather than, like, for example, a Microsoft where you have employees who work on building the software, Open LMIS is an open source initiative. So that means that multiple organizations are contributing their time, their funds, their resources, their development time to making the product better and building the software. I just kind of included a little graphic up here. It might be a little bit difficult to see, but these are just some timeliness factors that were taken from an implementation of Open LMIS. So previously, it took over 15 days with a paper-based system for data to reach the central level. So coming from a health facility up to the central level, it used to take 15 days for that information of how much product did you receive, how much do you need to get all the way back up to the central level. Using Open LMIS, it takes a day. So this kind of open source software can really make a huge difference when it comes to getting data there faster. It used to take 1 to 2 weeks for feedback reports to be sent to health facilities. It literally takes a minute now. So health facility managers are able to get feedback on their reports almost immediately in real time. You know, I won't go through every one of these, but as I was saying, the monthly reports and orders for facilities to request product, it used to take 1 day to 2 weeks for those orders to make it up to the central level. That can happen in as little as a minute now using this open source software. So this is just kind of making the case for why software can make a huge difference. Open LMIS is highly interoperable with other systems. So like I laid out all of those kind of different open source systems, Open LMIS through what we call APIs, which are application programming interfaces, make it highly interoperable with other pieces of software. So something like DHIS2, like I mentioned, Sage or Epicor, which are warehouse management software, Open MRS, which is the electronic medical records. So basically a country may have a DHIS2 instance already functioning to capture that health management data. When Open LMIS comes into the country and is implemented through these APIs, which is kind of a fancy software term that I won't get too far into, but it's a way of making systems be able to talk to one another so that you can share data from DHIS2 with Open LMIS, and then you could do something like accurate forecasting, where you could say, this is disease incidence, this is how much product we need, and you can compare those two data sets. So Open LMIS is very interoperable with kind of these other systems that can exist in a country that may already be there or may be implemented at the same time. So the Open LMIS community, like I mentioned briefly, is a global team of partners and donors. So Open LMIS has gotten the great majority of its funding from the Bill and Melinda Gates Foundation. But USAID has also been a major supporter since the beginning of the initiative. Initiative started, initial requirements gathering for the software started back in 2008, so it's been around for a while. But the first development and first implementation of the software occurred in 2013. So this is relatively new. Something like DHIS2 for the HMIS data has been around for many years, like maybe 15 years. So that really says something about how much attention has been paid to disease incidence and health data versus commodity data. There's kind of been a lack of focus or a lack of comprehension of how important having that logistics data is for getting, quality decision making and making sure product arrives in the places it needs to. Some other partners, the Rockefeller Foundation also provided funding kind of for the initial development of the software. And then other major partners, maybe some of you have heard of some of them, PATH, also based in Seattle. They're a very large global health organization. ThoughtWorks is a software development firm. They do a lot of global work. Gavi, which is the Vaccine Alliance. So Gavi is really helping to inform our work on an upcoming vaccine module. And then the Clinton Health Access Initiative has been a major partner as well, so also known as CHI. So these are just some of the major partners, and then JSI, where I worked previously. These are kind of the major partners that are supporting the software and are working to try and bring the community together. So just quickly, the Open LMIS vision is for shared investment and shared benefit. So being able to take that software and apply it in one country, and then being able to continue it and use it in other countries. So like I said earlier, there may be siloed kind of one-off programs, one-off systems that are applied in a country, and then they just kind of live and die in that country. Open LMIS is really trying to actively work against that by creating shared benefit. So when a donor pays for development within the software, that development through what we call our modular architecture, and this is kind of getting into the software background that I don't want to get too deep into, but the way that Open LMIS is architected makes it so that that software can be customized for that country and then reused in another country. So we're really trying to make sure that this software has a shared benefit across countries and that they can benefit from the lessons learned and the customizations that were done for each country. Another key benefit, like I showed earlier, it's highly interoperable. So through those APIs, we've really set up the back-end architecture of the software to make sure that it's interoperable with those other existing systems. And then finally, it's configurable and extensible. So it can be configured in a number of different ways. One program, many programs. So just family planning or family planning, HIV, TB, vaccines, basically any program that you can think of. Levels, locations, approvals, schedules. So the software is highly customizable. It can be put into any language, and then it can really be customized to manage kind of whatever kind of supply chain and system is existing in that country. So current implementations. Open LMIS is, the initial implementations were in Zambia and Tanzania, and those were through the JSI USAID Deliver project, which is that project I mentioned earlier. It was one of the largest health commodity procurement projects through USAID. It had, I believe, a $5 billion ceiling. So that means that whenever the US government does any kind of aid, distribution of health commodities, it flows through USAID, which you probably know from what you've been studying. But that's basically the US government's contribution for health commodities. So that can be any kind of health commodities: condoms, HIV drugs, malaria drugs, bed nets, kind of any kind of provision of health commodities was flowing through the JSI Deliver project. That has now gone on to a different project, and a different company is running that, and that now has a $10 billion ceiling. So that gives you an idea of how much product just USAID is contributing to global health. And that product goes to, I don't know the exact number of countries that it's called the GHSC project. I don't know the exact number, but it's literally dozens and dozens of countries that are getting millions of dollars worth of product. So Open LMIS was originally implemented in Tanzania and Zambia. And then other initial implementations were also in Cote d'Ivoire, Benin, and Mozambique. So those are kind of the original, what we call the 1.x, the first sort of phase of the software. We've had expansions, so typically software will be deployed in a pilot region and then it will be scaled to a larger region. So it's been scaled in Cote d'Ivoire and Benin and Mozambique as well. This map's a touch out of date. This is no longer a planned implementation. Malawi will be deploying in July on our re-architectured version. So we're now on version 3 of the software. So I'm sure you've kind of looked at software and you know it goes in different versioning. So we're now on version 3. So Malawi is deploying soon, and then we have potential implementations in Senegal, Guinea, Nigeria, and DRC. So the footprint is really starting to expand for OpenLMIS. And so a lot of my work is evangelizing the software and really trying to push it out into different countries. So I just wanted to give a quick little personal plug for Peace Corps, because it's awesome. I don't know if any of you are considering Peace Corps, if maybe there's like an RPCV in the room here and there, but I just can't say enough about Peace Corps. Like I said, I was an English major. I went to a little liberal arts college over in Walla Walla, Washington. And I graduated and I loved my degree and I had a wonderful time, and then I kind of said, oh shit, what do I do now? And I had no idea what to do. I was not ready for graduate school. I felt like that was a big step that I wasn't ready for professionally or personally. I really wasn't interested in reading a single book because I had just read about 10,000 books for my undergraduate degree. So I was like, I'm done reading, I'm done writing, I don't want to go to graduate school, what do I do? So I applied for not AmeriCorps. What is the teaching program? No, what is it?
No, it's AmeriCorps.
Not AmeriCorps, it's the Teach for America. Yeah, I applied for Teach for America, made it to round 2 of the interviews and then got rejected. And I felt bad for 15 minutes, and then I was like, oh great, that's actually not what I wanted to do. And then I have no idea where it came from, but I just came into my mind. I was like, what about Peace Corps? And I wasn't one of those people who's grandfather did Peace Corps and grandma did Peace Corps. I didn't know anyone who had done it. I just kind of came into my mind, and I went to the Peace Corps website and I was hooked. And I was like, this looks amazing. They're going to pay for me to go live overseas for 2 years and be able to use my experience and to gain experience from people. So I applied. It took me about a year of application process. So it's a very long application process. It can be quite rigorous. You have to do fingerprinting and a lot of health checks, and there's a lot of work to do. But a year later, I left for Senegal in West Africa, and so I left in 2007. And I was there for 2 years. I didn't go home. I stayed for 2 straight years in West Africa, living at the level of the local people. You don't get paid, you just get a stipend. Forgive me if Peter's talked your ear off about Peace Corps already, but you really live at the level of the local people. And I already was a French speaker, so I got to focus mainly on the local language, which was Wolof. I became a fluent Wolof speaker, and I still speak Wolof to this day, and I'm actually going to do work in Senegal probably in about a month, and I'll get to speak with the people in their local language, and you can't imagine what a difference that makes to be able to greet someone in their local language rather than the colonial language that it was imposed on them. It makes a huge difference in my work. So it took me from an English major to being an information systems manager, and I can only say that Peace Corps was the bridge for that. It opened doors for me, and when I came back from Peace Corps, I was ready for grad school, I was committed, I was motivated, and I knew I wanted to do global development work. So I went to the university here, and I got a degree in international development and conservation, so I actually thought I would be doing conservation work. But JSI in DC offered me a job all the way from Montana and relocated me out there to be a little program officer in their giant project. And I got started on my way, and it's absolutely changed my life. So these are just a smattering of fun pictures from my time in Peace Corps. Yeah, and I can't say enough about it. So that's my just little personal plug for Peace Corps that I couldn't resist giving. So thank you very much. That's my,
Okay, thank you.
that's my speech.
We'll forgive her.
Yeah.
I see some, what do you call them?
RPCVs.
There are definitely some students who are interested in the Peace Corps here too, so that was fun. Okay, questions for Tenley on, it's really amazing to me that she has gone from being an English major to a information logistics specialist, and it's a huge jump.
No one's more surprised than me, Peter.
But really, it shows you how much you can do for health without being a provider, without being a health provider. There's so many things out there that are ancillary to health provision and prevention that are just as important as actually treating disease. And so I think from that standpoint alone, this has been a really refreshing talk for me to hear that. Besides which, you know, she got her degree in international development and conservation, but you know what she's really doing right now is straight out public administration, so she should have gotten a master's in the program that I teach. Okay, questions? Yeah, Chris.
Your colleague, I think her name was Jessica, talked a little bit about getting buy-in from the host country. So as you go around to these different countries, would you talk a little bit about the different reception that you've gotten or how you've tried to work through that?
Yeah, that's an excellent question. I'd be interested to hear Jess's perspective on country buy-in, because I think that's something that we often overlook or we don't necessarily talk about when we're presenting, is, you know, developing the capacity of the country themselves and getting their support and their buy-in for these activities. There are so many donors and so many organizations that are coming into countries and trying to, you know, provide their solution or sort of impose their work, and having the country buy-in is really the only way to have a sustainable solution be implemented. So, you know, when we're talking about data management and specifically, you know, an implementation of something like OpenLMIS, I would say that for Village Reach, the work that we do and what we really try to encourage in our work and our community is sort of country buy-in first. So I think it's maybe a thing of the past, hopefully, that we're kind of moving forward as a global health community away from, you know, this is donor money and this is the donor project we want to run and this is how we're going to run it. USAID has missions in each country, and there's definitely still some tension and push and pull between what a country wants to implement and what a donor or an organization wants to implement. So in terms of getting country buy-in, I'll just use an example of an OpenLMIS implementation, the one in Senegal that we're working on. We're working closely with a technical working group that is made up of not just partners, so not just external partners like UNFPA and USAID, but the National Pharmacy, the Ministry of Health branch that runs the LMIS work. So having their participation on those panels and on those technical working groups, I think, is the first step to that country buy-in, is so making sure that at every step of the way, ministry and country participation is secured in any kind of conversation that's being had. And I don't just say that to pay, you know, like we're kind of paying lip service to the country or we're just kind of including them because we have to, but they're the ones who really have the experience. They're the ones who know their supply chains inside and out. They're the ones who know the character of their people inside and out. They're the ones who really have the comprehension of how a country functions and what will succeed or what won't. So, you know, I think there's a number of ways that you can secure country buy-in, but I know that the way that we try to really function is in any kind of conversation we have, any kind of consideration, drawing in country participation right off the bat, kind of first step, starting with the ministry and then bringing in partners secondly. And in my work in Open LMIS, I'm kind of the face of Open LMIS, so I get a lot of the inquiries, we're interested, we'd like to implement, we want to learn more. And I would say that 3/4 of those requests come from ministries and country, actual national country programs themselves. So yes, there is a lot of interest from, the PATH country offices or the UNICEF country offices, but I would say actually the majority of the interest comes from country programs themselves. So I'm starting the conversation with those country program managers themselves first and kind of starting there. And if you start there and if the idea is germinated there, then you can bring in partners as the support, but it really needs to be the country leading it. So I don't know if that answers your question.
Follow-up to that.
Yeah.
When you say in Senegal, you'll start with a pilot,
Yeah.
smaller area. Do you require some kind of a plan for sustainability after you've left by the country? Or is there any accountability about that?
That's a great question, and a hard question. Yes, I would say that sustainability is probably the first word on ministry tongues when they're talking about implementing a program. Is this a sustainable solution? Is this going to be just another one-off program that lasts as long as the funding lasts and then it dies when the funding dies? So in terms of trying to set up a sustainable program, I think the way that we address that with Open LMIS, at least specifically, is to try to make a system that matches the country's processes and sort of normal function as closely as possible. So like I was talking about those paper-based systems, the way that Open LMIS, the software functions, the actual form that you fill out tries to match a country's LMIS form as closely as possible. So in that sense, we're focusing on sustainability by trying to match our work to existing country practices. So it's not such a kind of foreign concept coming in. In terms of sustainability, like with an open source software, this is not a piece of software that is being sort of paid for and imposed on the country. This tends to be supported by the ministry. Like I said, it's open source, so they're not paying to use it. Their focus is really paying for the training, the customization of the software, and then kind of the ongoing support costs. So in terms of providing ongoing support, another way we address that with Open LMIS is that Open LMIS community. So having that community of partners that's part of the open source community provides ongoing support for those implementations. So I think just in the way the software is developed and set up, it's tried to take into account those sustainability questions. So having it be open source, so the country doesn't have to continually come up with money to pay for a license. Having it sort of match the country processes, so it takes less time to install it in the country, and then it's quicker upkeep or quicker uptake of the software. And then also we have that community that kind of provides that ongoing support through a number of different partners. So I realize I'm kind of talking around your question because it's a hard question. And that's kind of the question that you address when you're in Peace Corps as well. It's like you come in for 2 years, you do your work, and then you leave. And how much do you know about the sustainability of your work? And that gets into this idea of capacity building. So we're not just taking our resources and our knowledge and bringing that into a country and imposing it and saying, here you go, here's your drugs, here's your program, and then we're going to step back when we don't have any more money or we're not interested. But how do you build the capacity in the country to manage that project or that program themselves? So I don't think I have a great answer because I think it's a hard question to answer. But I think we can try to set up our processes to sort of sustain that or push toward that as much as possible.
So I have a bunch of questions, and I want to put them into two groups. So the first group kind of follows up on Chris's question that we were just talking about, as to sustainability. What about the training component? Do you train people on how to use the open source? And who does that? And then connected to that, I have two follow-ups, which are, one, do you do anything with surveillance about errors, emerging and re-emerging diseases? Is that something that you can do through your systems? And then you also, it concerned me when you talked about waste, because I was thinking, are all of these paper documents just strewn about? And what does that have to do with privacy? I mean, if they're just lying around in the debris. So if you can answer those three questions, then I'll ask you my two tough questions after that.
So let's see if I can remember all those questions. We're talking about privacy with paper-based systems. We're talking about training, and then also surveillance. So in terms of training, the training is usually conducted by the countries themselves. So there may be implementation partners who could be a technical implementation partner that comes in and helps kind of provide the initial support for setting up the software. But typically an implementation uses a local software development organization or shop. So, using local software development resources to actually do the customization of the software. And then in terms of training, that's typically a combination of ministry and partner. So whoever the implementing partner is. So if it's UNFPA, who is paying and sort of running the implementation, they would put together a training plan along with the ministry. Does that kind of answer your question? Yeah.
You don't do that yourself then?
Not the training specifically. That's usually, I think the implementing partners tend to try and do as little of the sort of outreach as possible on the software. So trying to get, like I was saying earlier, that country ownership, having the countries themselves perform their sort of training on the software is I think, an essential point. And then disease surveillance? What do you mean? What's your question?
Well, there's a lot of talk that by building up the capacity of health centers in the Global South, particularly including those that are in the most remote areas, that this serves another purpose, which is that the information then can be, if there's a disease outbreak, can be rapidly transmitted back. And so we can kind of, and there's groups that are now doing maps and stuff like that of that kind of thing. Do you plug into that at all?
That's a great question. We've been approached by the CDC a couple times, specifically asking about not necessarily the disease incidence side of it, but the response side of it. So say you have another disease outbreak like Ebola, and you need to rapidly deploy treatment drugs for that particular disease incidence. CDC has approached us about, is our system a readily deployable, quickly deployable system that can rapidly track sort of the inventory management, because CDC holds huge stockpiles of drugs for treatment of these kinds of disease outbreaks. So they sort of rapidly deploy that into an area, but then they need some kind of data management. For inventory management, where are these drugs being distributed, kind of like a quick and dirty LMIS system to respond to those kinds of outbreaks. We've been approached by CDC to talk about that. Right now, the way OpenLMIS is set up and functions, it doesn't quite have that out-of-the-box functionality to be able to sort of do a rapid deploy. But I think that's certainly something that we're looking toward, and I think there's a large, I don't want to say market, but there's a large need for that kind of quick deploy software. So.
Okay, and then just quickly about the paper products flying in the breeze.
I don't know. So countries tend to be very particular about their patient and health information. So no, it's not like it all makes it up to the central level and then it just gets thrown out the window.
There's no waste management system. That's what certainly, if there's no system of destroying these things, then they're gonna be flying around, it seems to me.
Nope, they sit in giant boxes, in giant rooms, in giant crumbling buildings in the middle of a capital city somewhere in Africa, and they never leave. So there will be boxes and boxes and boxes and boxes of LMIS forms from like 15 years ago, just piling up in these rooms with nowhere to go.
Okay, my last questions are, one, what have you learned about reverse learning? I ask this question of everybody. What do you learn out there that you can then take back and apply, or we can take back and apply here? And the second question is, you talked about large sums that USAID has put into this whole process. But isn't USAID on President Trump's chopping block? So what do you think is going to happen?
So I'll actually answer the reverse question last. Yes, you're absolutely right. I think USAID is one of the organizations, unfortunately, on the chopping block, which makes it really difficult to predict the future for this kind of work. When you don't support the kind of systems that are providing product or providing stabilization for these countries, and then planning on destabilizing things through war or anything like that, it's kind of a frightening situation, because you need to have these stabilizing organizations like USAID, the Department of State, that provide that diplomacy and then provide that support. So yes, you are right. USAID is probably one of the areas, along with State Department, that's going to receive some cuts. So we'll see what that's actually going to look like. But I think right now the funds are probably earmarked for a little while. But it's a good point that there's a large amount of money that may not go into the drugs that are being sort of distributed and donated to these countries. But there's a few ways to look at the donations of drugs to countries. Is that this is something that I kind of question myself about? Is that the best way to provide commodities and healthcare and health products to those countries? Should there just be massive donations of millions of dollars worth of drugs that just are given to these countries for free? Or that starts to get into a question of economics and kind of participating in a global economy, and how much of that is what kind of, that's a different consideration and a different conversation. And then for reverse learning, I would just go back to my Peace Corps experience and say that I had all these grandiose ideas that I was going to go into Peace Corps and go to Africa and teach them about, I did urban agriculture, and I was going to teach them urban ag, and I was going to teach them all about fruit tree grafting and display all my learning, and I ended up dispensing quite a lot of information, but receiving far, far, far more back. And so when you're asking about USAID and sort of cuts to those kinds of programs, and I'm sure Peace Corps is also probably on the block for maybe some lower funding as well, I would just say that what you learn from these countries is far more than you may be bringing to them. So I think that's a really good question.
Just as a happy note, 182 House members who signed an open letter to keep Peace Corps funding as it was last year.
Really?
Bipartisan.
Great. Bipartisan support. That's fantastic. I didn't hear that.
Trump's budget does have to go through congressional.
Absolutely. Well, alhamdulillah, as we say. Yeah.
Dorothy's got one last question.
Yeah.
Is there, when you go in and implement the system, is there any specific feedback you've gotten from countries to change the system, or that have been added to new versions of the software?
Awesome question. That's a really good question. Yes, absolutely. We do. So when you're informing or when you're developing this kind of software, you do what's called user requirements. So you basically, like this trip to Senegal that's coming up, I will go there for a couple weeks, and I will travel through all different levels of the supply chain, starting at central and then moving down to regional, district, and health facility. And then you ask, how do you do your system? How do you do your LMIS reports? What do you need to see in the software? Like how do you want to use this software? Very open-ended questions. And then software gets developed based on that, right? I mean, that's all it really is people tell you how they want to use it, and then you develop it based on how they said they wanted to use it. So OpenLMIS was developed using user requirements from, I want to say, 8 or 9 countries. So we really went out and developed the initial requirements for the software based on actual user requirements in country. But there's certainly been new features and functionality that are requested. So things like what we call batch reporting. So instead of just a program manager being able to see one report, they want to be able to see aggregated reports from a number of facilities. But that doesn't exist currently in the software. That's something that we're being asked to do by a specific country. And so we're trying to estimate that in the OpenLMIS community. Is that a requirement that we want to develop into the core software? So that's a really good question, because we're constantly going back and forth with individual country implementations and the customizations that are done for that country to sort of meet their specific supply chain actions. And we're constantly saying, is that applicable in a global context? As in, is what is being done in Malawi for their specific supply chain, like I showed in that supply chain image, it can be so unique for every country. Is what they're doing in Malawi, this particular functionality, is that something that, I don't know, Cameroon would want to use? Is that a global feature that we would want to pull out and then apply to a new release of the software? So that's a great question. We're constantly reviewing kind of the user requirements and the way software is being customized for an individual country. And when I said that we're trying to make it sort of global, extensible, shared benefit, that's what I mean, is we take that utilization in one country and try to apply it globally.
Do you know what country specifically is asking through the batch reporting?
Yeah, so that was Malawi, I believe. Yeah, that was Malawi that's asking for that. Why do you ask? Now I'm curious.
Project on like reverse, like taking things being implemented in like third world countries and applying it to like the U.S.
Interesting. Okay, cool. Yeah, I'd love to talk to you later. Yep.
Yeah, that's great that Tenley's willing to stay and talk to any of you individually. You know, we have this celebration event on May 3rd where we're hoping to have everybody who is a speaker, as well as all of you and faculty in the Global Public Health Program attend. I don't suspect that's going to work for you, but if you could be back here on May 3rd,
Oh,
we'd
that'd be
love to have
really
you.
fun. I would
So
love to.
join me in thanking Tenley for her really interesting.
Thank you.
Just looking ahead for next week, Bob Quinn, who is an organic farmer and president of Kamut International and lives in Big Sandy, Montana. He's going to be here to talk about, can the health problems created by modern wheat be solved with ancient wheat? So a really interesting, kind of different discussion, one that I think Chris will be especially interested in. So that's next week.